All right, I'm going to introduce Dr. Joel Funk. Joel is an associate professor at University of Arizona. He's got a number of titles, including Associate Director of Perioperative Services, Chief of Staff, South Campus, Chief of Surgical Services, Director of Urologic Surgery, among others. We have a common root. We all went to Northwestern. A number of us here went to Northwestern. And he also did his college here in Michigan at Aquinas College. Joel is unique or fairly unique among the speakers in that he didn't do a fellowship to learn HoLEP. And maybe, Joel, you could say a few words about how that happened, because I think we would like to see more of that going on, because not everyone can fit into a limited number of fellowships. Joel is going to give us a talk about the top-down approach, and hopefully show us some videos and give us some pointers on that. Okay, come on up, Joel.
I'll screw the slides up at least 4 times, and I do see the mic, so if I decide to walk around a little bit. I tend to be interactive. There's lots of video. My wife says I'm a visual learner, so you guys get to be visual learners as well today. I first want to thank University of Michigan, particularly Dr. Casey Dow for the invitation, and John. As a born and raised Michigan native, if any of you know where Fremont is, 2 stoplights, that's where I'm from. To come back here to this institution is amazing for me, and I'm incredibly grateful for the opportunity. My disclosures: I am a proctor and preceptor for Boston Scientific for people who are on their journey learning enucleation. And briefly today, the majority of our time we're going to spend on a technical overview of the top-down technique that Jim Lingeman and Nadia York developed in Indiana. Some potential advantages, my thoughts on some challenges related to that, and just some closing remarks. And please stop me or interrupt me. We'll have a lot of downtime because I'm Gen X. I don't know how to put sound in my videos. If my videos work, that's a success. So just as an introduction, I think we all know that HoLEP is a completely size-independent technique, and in my opinion, it is the gold standard. It is superior to TURP in multiple parameters, certainly equivalent to a robotic-assisted simple or open simple, with some of the advantages we've talked about in previous presentations, with extremely durable results. I've been doing HoLEP for 15 plus years. I have never reoperated on a patient for recurrent obstruction for adenoma. Bladder neck contracture happens to all of us. Literature is about 1 to 3%. Our experience is about 1.5% at Arizona. But that really is the primary thing for which patients get reoperated on after HoLEP. It's not residual or regrowth of adenoma. And certainly, as John touched on, HoLEP has lagged in adoption due to this perception of a prolonged and steep learning curve, and really technological improvements that we've made over the last 3 decades have failed to really propel adoption. And technique modifications, in addition to that, have been implemented to try to shorten the learning curve, and the top-down technique is one of those that Jim and Nadia developed to that end, to try to simplify or shorten this learning curve and improve kind of that perception of how do we do enucleation. The traditional 3-lobe technique's been modified. We'll hear talks today about en bloc technique. Dr. Dow already gave a great presentation on modified Gilling 2-incision technique. And really, these modifications have been done to shorten that learning curve, to try to reduce that transient incontinence. And most of these are based on the direction of enucleation, how we release the external sphincter at the apex, and ways to maintain a single dissection plane to maintain our orientation throughout the enucleation portion of the case. As I said, Nadia York, who any of you who know her, she is a force of nature. And I met her maybe 10 years ago when she was Jim's fellow, and was blown away by her. I think that Dr. Gilling's the one who gets to interact with her the most currently, but she's amazing. They introduced this technique. It was a video presentation that they did back in 2017, and really the goals were those of reducing the operative time, reducing our tension on the external sphincter, which at that point, most of us were doing an encircling technique, as was in Casey's video. The big difference conceptually is moving anterior to posterior as opposed to posterior to anterior. A couple videos here. The top video is more traditional posterior to anterior approach. These are real-time videos. I don't have anything that I've sped up here. The bottom video is part of the initial top-down approach. So we can see that we're starting anteriorly, not posteriorly. And we'll talk about, how the thought process is or what the theory is as to why that this aids in learning curve and operative efficiency. We can certainly sit through the whole video. It's a couple minutes long, probably not necessary. You guys get the idea of just the concept is different, front to back as opposed to back to front. Traditional posterior incision is how you start a top-down technique. When I do this, I will do this either a 6 o'clock incision, 7 o'clock incision. I let the prostate tell me where we need to go. This prostate doesn't have much of a median lobe, so we're basically making a 6 o'clock posterior incision from the level of the bladder neck down to the viru. I do use a working element as opposed to a fixed laser bridge. Dr. Kuntz developed this. Peter mentioned him earlier. It took me about a decade to adopt it. I will never go back to a fixed laser bridge. I do think that it's faster, and I think that, as I'll talk about later today about learning curve and training, I think that, like a lot of things, we look for transferable skills when we teach, and my residents are more comfortable grabbing hold of something that feels like an aglacius that they've used for a TUR of a bladder tumor or a TURP at an outside institution. So there's some level of immediate confidence. So there are breadcrumbs for us, fortunately, on this prostate. We see the prostatic concretions, which tell us we're virtually on that capsule. And we want to develop this entire length of this incision. I think that when people learn HoLEP, there's a tendency to stay at the bladder neck with these incisions and not develop the whole length of the incision. What happens is you start to limit your ability to reach the depth of the proximal incision because of distal adenoma thickness restricting your scope. So you really need to create that entire groove for your scope to be able to sit in to progress in your enucleation and get down to the capsule. After that posterior incision, the contralateral 12 o'clock incision is made from the level of the bladder neck down to the viru. The upper video here, I skipped it a little bit. My approach to this is my scope's inverted. As a general rule, I'm always trying to work with it being oriented from the center of the urethra out to the capsule as lens, fiber, capsule. So if we're working at 12 o'clock, the fiber is at 12 o'clock. If we're working at 3 o'clock, the fiber is at 3 o'clock. Some of you may notice my working element has been customized by my sterile processing department in this video. So there was a pause where I took it out and straightened it because why is my orientation so weird? But it was the best video I could find of doing the anterior commissure at this point in the surgery. But just like the 6 o'clock incision, we're making this length, we're setting the length, and the way I set the length initially is inverted. I raise my hands way up, I look at the viru, drop my hands, stick my fiber out into the bladder neck, and try to set that length in that first pass. And then work to deepen that groove down to capsular fibers. And when Nadia described this, the next part is really to start to work this incision laterally at the bladder neck in these kind of short little incisions where we're watching the direction of the bladder neck fibers. We can start to, hopefully you can start to appreciate that those are starting to curve there a little bit. So we're making these short incisions and then giving it a little bit of a mechanical push, and we can see that we're starting to get on capsule here proximally. One of those pitfalls of this, I think, is we all feel more comfortable when we're farther away from the sphincter, but we've got to widen that incision over the whole length of the anterior prostate and really get on capsule for the full length. Because if you leave this distal bridge of adenoma that isn't on capsule, when you go to make that blunt move, you can't separate the left and right lobe. They're stuck together distally. And you really end up starting to dig through a lot of adenoma. you lose the anatomic plane, and we've gone from doing a anatomic directed operation to what I call a plumbing procedure, just resecting prostate like we would with a TURP. That top video, you can see that we're working distally, trying to finish off this adenoma, and kind of that fluffy, I call it burnt styrofoam appearance, is typical of adenoma, so that we can kind of curve the mucosa down and around. The people who are paying attention will notice that as we go down, we have not done the posterior incision. In this particular case, we just elected to start with the anterior incision. But the goal here is to get those two incisions started so that we can connect the mucosa at the apex under direct vision and avoid that complexity of trying to do an encircling technique of that distal mucosa. This is continued dissection behind the left lateral lobe. My tendency, whatever technique we're doing, is we're widening the bladder neck, and one of the general principles I try to teach is you primarily want to work from distal to proximal, whether we're doing a top-down, whether we're doing en bloc, whether we're doing a more traditional technique. When you work distal to proximal, you're constantly seeing the orientation of the capsule and the adenoma and where you want to work. You're not kind of trying to guess and move your scope in 3 dimensions and pull back to the distal extent that you need to be and keep all those variables oriented. So we're working on dropping that mucosa and the distal adenoma down on this video. Don't think that we have to belabor that, but basically a combination of, like any technique, mechanical and laser energy, and connecting that anterior incision to the posterior mucosal incision, both on the left and right lobe. And it's interesting. I do not think that Nadia and Jim actually have published this data. To my knowledge, it was video presentation from the AUA in 17. Smaller number of patients, but mean enucleation time and particularly grams per minute, which I think is one of the measures that we all use about how efficient we are at enucleation, did seem to be superior. But not a lot went on after this to really systematically look at the technique and compare to a more traditional technique. As Casey mentioned, the bladder reentry is pretty straightforward because you're starting with that 12 o'clock incision. You've got gravity pulling the gland posterior slightly, and those were the ideas as to why this has some potential advantages in our operative efficiency beyond the ease of assisting in that learning curve. Hazim El-Halali and the folks up at McGill actually just have published this in the last year. Hazim's been doing this for about the last 18 or 24 months, really looking at top-down systematically. And contrary to Nadia and Jim's data, really not any significant difference between the two techniques. And I think, as mentioned earlier, I think that it's an option here that every one of us has to decide, where do we want to use it? How do we want to deploy this technique in our patient population? I think that some of the challenges, obviously, as I've mentioned, is there's really not a lot of trials comparing the technique. And those that have been done are extremely experienced enucleation surgeons. I mean, thousands of cases under their belts. And so I don't know if that can be extrapolated to the goal of this, which is easing the learning curve, right? Because the person who wants to have an easy way to do this has done 5, 25. So without that data of someone actually in their learning curve, I think that it's really tough to say, is it better? And it interestingly hasn't gotten a lot of attention. En bloc certainly has gotten a lot more, and I think that that's driven by a lot of our colleagues outside the United States. When I started to do en bloc, it was basically the same reason that I went to the working element, which was peer pressure from others of, like, you really got to try this, you really got to try this. But I don't know if we know how this fits in, both compared to traditional, but also to more modern, though I will say the caveat, don't know if they're better techniques like en bloc. And early apical release, however you do that. I think a lot of us do this in combination with any sort of incisional technique versus en bloc. but I think that we've all moved to trying to liberate that sphincter earlier. And I think that identifying, when I've done these cases, identifying the capsule anteriorly can be a challenge. Um, I think that that is one of the particular advantages to either the omega incision or the 5 and 7 o'clock sulcus incisions initially, where it's the easiest to find the capsule right there lateral to the viru. So when you're making a posterior or anterior incision, assuring that you're down on capsule, I think, is technically a little bit more difficult than trying to identify it at the apex. And as I mentioned earlier, that challenge of I don't want to cut the sphincter, and having confidence in making that anterior commissurotomy long enough when you start it. I think we all tend to make it too short, and then we struggle with apical adenoma being stuck between the two sides. Just some final thoughts. I mean, generally my editorial is that maybe it's slightly faster for enucleation, but there's probably not enough data to make that argument strongly. I do think that there is some ease in addressing that apical mucosa compared to an encircling technique, which likely results in less tension on the sphincter and probably less anxiety for us as a surgeon, probably more so than any change in the clinical occurrence of transient incontinence after the surgery. And really, if this is something that people are interested in, or we want it, we need to study it more rigorously to really determine how does this compare to some of our other techniques. It's an amazing operation. This is a patient. This was a post enucleation CT out of some concern for a bladder injury. One of my former residents sent me these images about 6 months into his practice, and fortunately there was no bladder injury. But the comparison where you just see that entirely open fossa with that Foley balloon sitting in it it's just so satisfying when you see this massive Goomba that you started with, a day earlier, and in less than 2 hours you've changed this patient's life. So thank you again for the opportunity. This is Lola. Anybody who comes to Tucson, she has spare kisses and lots of love, and she will not let you get off the sofa. Anybody's welcome to visit her. So, thank you.
Joel, thank you for a great talk. Couple of questions about how you do it and the technique. Can you describe the early release that you actually do? Where do you do it? Where do you cut? How deep do you cut?
So the majority of our cases now we do en bloc. And we can dig into it now. We can dig into it and the other talk about education, learning curve stuff later. But our approach is typically 5 and 7 o'clock sulcus incisions, a mechanical push to start to raise that apical mucosa, and then what I call progressive mucosal curtain release. So you can start to see that the mucosa is lifting up off of at that connection, and is kind of like a trampoline between the adenoma and the sphincter. So we'll do a little mechanical push. We'll take the mucosa up a little bit. Then we'll progress our lateral dissection, pull back, and then once we get to that point where, as Casey mentions, kind of you can get your entire mucosa in one field of view, which is generally 10 to 2 o'clock. Then we'll connect the mucosa across apically. So it's not a, I watch a lot of videos. It's not one of those direct, like I'm going to go deep initially at the apex, because I consider this a safe space. You wouldn't be here if you weren't interested or weren't doing HoLEP. My honest opinion is a lot of those aggressive early apical releases, the reason they're so low transient incontinence in their anecdotes is because there's apical adenoma that's left behind. And I think that if we MRI'd all those patients with Shane, we would see that there's particularly anterior apical adenoma that has not been enucleated. That's fine. Patients still do well, but I think it's a little intellectually dishonest in that situation to quote the durability of a true, Gilling enucleation to those patients.
So the other question is, on the anterior posterior technique, how far posteriorly are you taking your dissection?
So typically the goal that I set for a top down is as long as you've got the entire gland split anteriorly, we'll take that around to about 9 and 3 o'clock. And then we'll start to, because we'll have that posterior incision as well, and we've popped the apex off posteriorly on both sides, I call it the distal pivot. And where that lateral and posterior dissection connect, you want to work from the most distal portion of that where you can kind of swing around the lobe and progress that proximally towards the bladder neck. So once the mucosa is split, once we've got a good plane laterally and posteriorly, then we can progress the rest of that lateral dissection kind of between 2 and 4, 3 and 4, that kind of thing, on both the lateral lobes.
Excellent talk. Thank you so much. I have two questions. I want to go back to what you were saying about leaving apical tissue, because this is something I have thought about many times, especially as we start doing more en bloc, more early apical release. Maybe we should be leaving tissue back there. Maybe we should be leaving a bolster back there. Maybe then it's more like aquablation, right? So aquablation has no anterior
Right.
effect at all. And the transient incontinence rate is supposedly lower. So I don't know the answer to that, but it is intriguing to think that, well, maybe that's a way to intentionally do it. That's the first thing. Second thing, specifically about top down, I think, particularly we saw in the MRIs like how different the configuration of the prostate can be from one patient to another, and we've all been there where like literally you cut the anterior commissure and you have to like go up and over, like an iceberg almost. I find that's what's really hard with the top down, because like anticipating the angle can be really difficult, and then you're really torquing
Yeah.
to get up and over top. So even though you may not be cutting, you are definitely still, I think, causing some
Yep.
sort. And if you pulled back and looked at the sphincter, you can actually see that it looks ratty.
Right, right.
So just any thoughts about that?
I agree with you, Nicole, that I think that the transient incontinence is probably distraction of the sphincter. It's not the demucosalization. Maybe that plays a role in dysuria. But it's that distraction, the stretching of the sphincter that occurs. And I think that there's data to support that, in that you look at scope size. I mean, I typically use a 26. I'm like Casey, I'd love to have a 24. I'd love if we could use that 22 French Princess scope from Wolf and get a morcellator through it that morcellated more than 2 grams a minute. But Marwan has this data from Baylor, Scott, and White. When they went from 28 to 26, their transient incontinence rates were lower. So it makes sense that whether it's tension, whether it's transient ischemia due to compression from a larger scope, lots of people get up to microphones at meetings and give their opinion as to why it occurs. But there is data forthcoming, but there's not a lot of data as to why that occurs. And the other hat I wear, I've got a weird practice. I mean, it's probably 80% HoLEP, BPH, and 20% female urology. So, if we talk about like neurogenics and particularly DSD patients, like we don't do sphincterotomies anymore because they didn't work. When we intentionally cut the external sphincter, it failed. The body healed. And so it's not cutting of the sphincter. Is it tension? Is it pressure? Is it, as Shane mentions, is it the declining lean muscle mass that every human experiences after age 50? It's not age, 75-year-old, it's his lean muscle mass. A guy who's a triathlete in his 70s, I'm not worried about him being incontinent. It's the guy who has a high frailty score and can't pick up a bag of dog food because he doesn't have lean muscle mass anywhere, including his pelvic floor.
I just remember, Joel, I wanted you to speak to why you picked up HoLEP. You're one of the folks who didn't do a fellowship. Why and how did you end up doing, barriers?
I'm going to save that for this afternoon. Okay. I'll save that for the learning curve one. So, yeah, go ahead.
Just coming from somebody who's really not really sure how my technique will develop, because I'm fairly early on the learning curve. When you release that anterior adenoma and you take it down, I guess I always wonder or worry about when I come posteriorly, things kind of flopping down into the field rather than being held up and not being able to develop that posterior plane as well. Can you speak to that?
Yeah, I think that one of my messages is that really your retraction is the key thing, right? And retraction for enucleation isn't active, typically is not actively like, I'm going to move my scope to where I think the junction is, and then I'm going to use my scope to pull the adenoma away from the capsule. It's the passive retraction that you get just from your scope being a wedge in that space. And so your working distance is typically particularly close. Like my laser fiber, what my setup, it is literally barely in my field of view because I want to, with a working element, I want to be able to reach out if I need to. But also when my scope is closer like that, it passively is providing the tension so that when I hit that with a laser pulse, if my tension's right, that space is going to pop open on its own. So your scope's going to kind of hold the lobe up and away from that junction. And it touches on another point why I'm sure somebody else will talk about it. I'm not trying to steal thunder. Holmium is, in my opinion, the right wavelength. I mean, we've spent the last year and a half looking at every single available other wavelength that's FDA approved that we can enucleate with. That high peak energy pulse that you get with holmium is critical to getting that space to open up for you. And it's magical when you've got the tension right. And that's really where you start to pick up speed is you're shooting out with that laser energy. You're not using it like a knife and the space just pops open and you're like, this is like dotted lines for me to enucleate along. Great, thanks.
All right, so I'm going to give a talk. The title of can you bring up slides? Okay, the talk says Michigan HoLEP, and I have to tell a story why it's called Michigan HoLEP. Ganesh goes to me, you need to make a video about how you do HoLEP, okay? And then he goes, I like the word, I like it called Michigan HoLEP. He likes the sound of it. So that's why the truth is, it's not Michigan HoLEP. We all do it different way. Casey, as you see, does it very different than I do. But it is a little bit of different from the classic gilling approach. So I didn't do a fellowship. In fact, as you heard earlier, I was a green light aficionado for many years. And with my frustrations, I decided to learn how to do a HoLEP. I got Mitch Humphreys to show me how to do it. He came over, proctored a case or two, and then I was off and running. One of the things you'll learn if you didn't do a fellowship is basically you don't know the right way to do it. You don't know the wrong way to do it, and you just pick up things along the way, and you read things, and you try different techniques that people talk about, and you keep the best of everything that you learn. And that's pretty much what I've done here. So I was very enamored with a couple of studies that I've done, Dr. Gilling, of course, but there's a paper out of Japan in 2010, so this predates Nidia's work, where they talk about this anterior-posterior technique. And in this paper, they actually go from anterior 12 o'clock all the way down around the prostate, and you know, people who've done HoLEP, you could do that all the way down to 6 o'clock. You could come across the mucosa without ever incising the mucosa lateral to the verumontanum. You just come all the way around and cut through. And that's kind of what they do here. They had nice pictures, anatomy, and I tried it. And the problem with that is when you do that, it gets hard when you're doing the top-down. As Joe was saying, you get to about 3 o'clock, it's hard to torque the scope past that, especially at the apex where it's short. So that's a problem. Of course, you all realize that if you do it from the bottom up, it's not a problem, right? If you take the incision, the classic gilling, up to 3 o'clock, it's actually very easy. So there's a number of steps that I do here. The first step is the classic gilling. Okay, I did speed up the video because this is the entirety of the case. Entirety of the case. I also want to talk about small prostates for doing HoLEP. So what I decided to do is I'm going to show this Michigan approach on a small prostate. So this is a 22-gram prostate, and because it was small, I'm going to show the whole video. But it is accelerated. It's a 2x acceleration. The beginning of it is a classic Gilling approach. We're going to make an incision from the bladder neck to the viru, and then lateral to the viru to the apex. And one of the hard things, challenging things with a small prostate is because you don't have that large lateral lobe mass, when you make this incision, you find the capsule, it's hard to push the adenoma off. I mean, the capsule is there, but there's not much mass. And when you dissect the apex, at least the way I do it is I start at the mid-prostate, you dissect the lateral adenoma off the capsule, and I stick my scope between the capsule and the adenoma, and I use that as a leverage to reach the apex. Well, because there's not much mass there, it's actually harder to do on a small prostate. But if you are persistent and you dissect along the capsule, and you find the capsule, when you get to the lateral prostate, you can surely do that. And I tend to do this dissection from bladder neck to the apex. And then when I get to the apex, I kind of say, you have to come to 3 o'clock around the apex. Just come to 3. You don't, and that's easy to do. I mean, you could go all the way to 12 o'clock. I just come to 3 o'clock because that's easy. And here you see the capsule about mid-prostate. And normally, and you'll see me struggle a little bit here, try to stick the scope underneath the capsule, underneath the adenoma at the capsule, but there's just not much tissue. But you keep pushing, and eventually you get around. All right, coming around. And here I'm making some progress, freeing it up. And I would also point out that when you're doing this posteriorly, like any other prostate, you're looking at the peripheral zone and you get nice capsule. When we get up top, and you'll see the next part of this, capsule doesn't look like this. I mean, it just looks like fibrous tissue. You don't have nice planes as you do on a big prostate. So here we are coming around to 3 o'clock. Just got a little bit more mucosa so I could finish the apical dissection. That's good enough. So one of the landmarks that I use when I do the apical dissection like that to 3 o'clock is I always look for these fibers. They come at the end of the adenoma. You're dissecting from 6 o'clock to 3 o'clock at the apex. And the capsule will always turn up, and you see this striking fibers that always go almost up and down when you get to 3 o'clock. So that marks the end of my dissection. I'll make that cut, and I'll always go retrograde towards the bladder from there. So then I do an early release, and everyone has their version of early release. And what I do for the early release is I cover the verumontanum. I go anteriorly, and again, this is a small prostate. So when I do an early release here, I'm at the bladder neck. On a larger prostate, you may be quite a distance away. And I make a transverse cut from left to right, not an omega cut, and I make sure that my incision is all the way through the longitudinal fibers. Basically, the capsule is behind there, just like posteriorly. So I cut all the way across until I get to the capsule. Then I'll free everything off the capsule. So now the capsule is cut. I come back into the urethra at 12 o'clock. Again, small prostate, so there's not much there. And I will make the incisions kind of like you saw Joel do. And I do this zigzagging move because, like Joel says, you want it to be a nice wide cut, not just a linear line. Make a nice long wide cut all the way back to where I marked my distal dissection. So my first cut, the early release, dictates how far distally I go at first. And there are some cases where I will go a little bit more distal to get around the top of the prostate, but most of the time that is a fairly good judge of the first cut. So here I found the capsule in the midline, and I'm just dissecting. Here you'll see me just go a little bit more further. I'm finding the capsule, and I'm doing a lot of pushing, and I'm just next to the adenoma until it frees up. And at one point, you'll just see what looks like a good-looking capsule as you do this, and then you dissect towards the bladder neck. You see right there, you see the capsule, and then you cut the urethral fibers that go to the bladder. And then once you get to this point, it becomes pretty easy. And I'll carry this dissection from the bladder neck all the way distally to the apex. This case is a little misleading because it's a small prostate. It happens very quickly. So here I'm pushing the adenoma. You see capsule. Just follow that line. And just progressing towards the apex. And then at one point, there you see a little opening. That's my lower incision. For a small prostate, it just comes up. It's so easy. It's just there. For a larger prostate, I have to work my way all the way to the apex, and then I'll find that. All of a sudden, you find that window. And of course, once you find that window, it's that aha moment, and just basically cut everything in between, bring it back to the bladder neck. And when you go distal from there, you'll actually find the mucosal bridge. This is when I'm just taking everything between the two incisions. A little nodule in the capsule left behind, so take that off. Here I'm looking for the mucosal bridge. And one of the things I do for a small gland is, for a big gland, I think it's okay to trap the mucosal bridge like Lingman has taught. For a small prostate, I think if you do that, you put a lot of torque on it because the prostate is fixed at the bladder neck and fixed at the apex. And if you try to stick your scope in and sweep it medially, you're really putting a lot of tension on the sphincter. So I always, for a small prostate, I always come back into the urethra, look for the mucosal bridge, and cut it that way. Okay, and this is just finishing off at the bladder neck. And then we do the contralateral side. And the prostate capsule at 12 o'clock is not a true capsule, not a surgical capsule. There's no compressed peripheral zone there. It's just an anterior fibrostromal tissue. And I start on the side where I see capsule well, and basically I sweep to the contralateral side along that plane. And by pushing on the adenoma and lasering the capsule, I free up the contralateral adenoma. And I do that all the way to the distal dissection to about where I did my first early release. And then just go back and take all the other fibers. You see, as you push on the adenoma, again, all of a sudden, the capsule releases, and you can see the capsule much better. Here I am taking the urethral fibers off the bladder. And there's no reason necessarily that on my second side, that I go from top down. I just find that out of habit. I'll do from bottom up to 3 o'clock, then I do top down. And then on the second side, I do top down, and then I'll do the bottom up. but you could do it any order that you like. Doesn't really matter. And I would say for most of this dissection, and here's something that you could do on a small prostate, it's harder to do with a median lobe, is you can do an early release on the mucosa. So basically, I just cut the mucosa there. So when it flips over, I don't have to go back and dig for the mucosa after I flip over. I just cut it to the bladder neck. But what you see here on a small prostate looks identical to a large prostate in terms of doing the HoLEP. So, the argument is, why did you do this on a 22-gram prostate like this? Well, because I use exactly the same equipment. This particular case was 19 minutes to do the case on the pedal. Okay, so it doesn't take any longer or less time than to do a TURP. And the result that you get when you're done looking at the prostate fossa, you're down to capsule everywhere. It's just so much more satisfying than if you do a TURP on a small prostate. And here you see I went to the posterior. I'm going to bring this to 3 o'clock. I always find the second side is easier.
John, do you cut the bladder neck at the end of these cases for small prostate?
Yes, I do. So you see, and my cutoff is 40 grams. I just kind of made that up. When I first started to do this, I did see more contractures, bladder neck contractures with doing small prostates. So basically, after I do this, you'll see this in the next segment, I'll cut it open. And even I'll cut it open, even if it looks visually, to me, it looks like it's pretty wide. I'll just do it anyway. I used to judge and say, oh, it's big enough, and I figure I just can't tell.
And John, maybe those smaller glands have a bigger element of primary bladder neck obstruction.
Yes.
Going with their, so they might have a prostate, but also it's their bladder neck. Yeah.
Correct. They tend to have a higher bladder neck.
Yeah.
But you'll see in this case, and here I think I'm going to be doing his mucosal bridge. In this case, it actually looks, his bladder neck looked pretty open when I was done.
John, you made this look really easy. Why are these small glands so much harder for us beginners?
So I think it's harder on the anterior aspect because you don't have as much compression there. The capsule is harder to find. So that's one. But aside from that, I don't think it's any harder. It's just a matter that you don't have the mass that you're used to when you're doing the large prostates.
Yeah, I just don't think you have any leverage.
Exactly.
That is the huge key.
Exactly.
You actually made this case, in my opinion, look great from a capsular plane perspective. I often find even, that you're cutting out a prostate-shaped object, right? Like the
Yeah.
capsule is poorly defined, I think, just because of the size of the prostate. But I think it's all a lack of leverage. You can't
Yeah.
hit your scope because
It's certainly hard.
You just don't have enough gland to get purchased behind to really get into that plane. And I think that you can have 25 cc glands like this that have a beautiful capsule, but the consistency of having a mature capsule once you're under 75 cc's starts to fall off. You get a lot more amplitude in how good the capsule is in these small glands. You can have 5 of them that are like this, where it's like, oh yeah, that looks just like a 100 cc prostate. And then you've got a few that it's like, it just is sticky. And that combination of stickiness and inability to kind of wedge yourself in there, I think that's why they're challenging. Intuitively, it's like it should be easier. It's less I've got to work on, but the mechanics are so different.
I think one thing that you showed that I really liked here, I really don't like microphones. Yep, that everything is in front of you. So you're not going to get lost in a small gland.
Right.
And so that's the one aspect. And so when you were taking the mucosal strip on the left-hand side, I think the key with a small gland and something that is teachable and should be done is there is no need to encircle a strip in a small gland. when you pull back to the apex, you can see that centimeter of tissue from the two planes you've created on either side. Whether you take it up front or you take it at the end, that part of the operation is never going to get lost. It's just the physical, I think, challenge, like Joel said, of being able to obtain leverage and enucleate in a retrograde fashion towards the bladder neck that you're going to get burned at every step with small glands.
It certainly takes a little bit of doing to get to it. But nowadays, to me, whether I'm doing a 20-gram prostate or 120-gram prostate feels exactly the same. So this is to answer Casey's question about TUIP at the end. And if you look at his bladder neck, it's actually reasonably open, but I will cut it anyway. And my approach to this, 5 and 7 o'clock cuts, looking at the UO, and I cut it deep into the prostate, maybe not all the way to the vira, but close. And then how deep I cut to the level of the trigone. Just like if we were doing a TURP, you can cut down to the trigone, and that's the way I thought about this. I'm gonna cut it all the way to the trigone, and I've done this too, where I try to go deeper. Well, if you go deeper, you're actually undermining the bladder neck, and you'll start to see fat. So you can only go as deep as the trigone. And once I make these incisions, whatever little fibrous tissue there is in between those incisions, I'm just going to go dissect that off too, so that I have a flat bladder neck. And it's always kind of interesting to me. I take all this effort to spare the bladder neck fibers when I do my first incision, my first dissection. Then I go back and I cut it. But it makes no difference. This part gives you no added benefit for continence, for HoLEPs at all, for, I think, any BPH surgery. So I make that additional cut. TUIP, I clean up the stuff in the middle, and at least anecdotally, it seems to be better in terms of bladder neck contractures. So some of the things specific for small glands, it is harder to find the capsule anteriorly. I think they're higher risk for strictures. I like to cut the mucosal bridge, as Casey was just saying, from the urethral side. What I don't understand is on the en bloc technique, which you can easily do on small prostate. This is actually fun to do a en bloc on a small prostate because you just come around the whole side, is how they do the early release. So maybe we'll see that on the en bloc technique. Any other questions?
Who else cuts the bladder neck on these small glands?
Some 40 cc, I do the same as John.
Yeah.
So what gives me a little bit of pause, and I saw you said no, is granted it's a totally different scenario, but say you've done 120-gram prostate. We were talking about this in the break where all the tissue is in front of you, right? None of it is anterior. You talk about cutting down to the trigone. You leave a shelf there that almost looks like your bladder neck in a small gland that you could conceivably go through there and cut. And you've almost come underneath, right? You have like this huge, it almost looks like a vert ramp that you skateboard off of where the tissue was. We don't cut that. And I feel like your bladder outlet is probably the same size. Now you do have those big glands where your bladder outlet is so big you could put 120 cc's in your fully bleeding and still pull it back in the fossa. But you have big prostates where you have a bladder neck that is small. And I don't cut those. And I do think that cutting the bladder neck increases your risk of bleeding. Yeah.
I think their symptoms are so much worse afterwards. That terminal dysuria seems like it lasts forever when I cut the bladder. That's the only reason I don't do it.
And just like anecdotally, at least from my experience, I don't typically cut the bladder neck. The patients I've seen get bladder neck contractures are the guys who had small prostates or who had to redos. And then I end up like cutting, sometimes the redos, the prostate capsule is just so sticky, at least in my experience, especially in the smaller ones. And then I'll go too lateral, like the 5 and 7, I'll see fat. And then I'm like, crap. And most of the time they seem to do fine, but I can think of 2 patients in the last, I guess, like 3-4 years who've had a bladder neck contracture, and I can think, that's the only reason why I can think why they had a contracture was that I cut out too deep and they had urinary extravasation.
Okay, so I'm going to introduce Nicole. Again, many of you know Nicole already. She trained at UVA and did her fellowship at Indiana, and so that's her introduction to HoLEP with Dr. Lingaman. From Indiana, she moved to Vanderbilt, our favorite department that competes with us for residents, and faculty. She moved to Vanderbilt, And she worked there from assistant professor all the way to full professor. And she's done a ton of publications, too many for me to actually count, where she's currently director of endourology fellowship, director of division of endourology, and also vice chair for academic affairs. She's so well known around the country for HoLEPs that I find that I refer her patients that live in the area to do HoLEPs. So I'm pleased to have Nicole come and give us a talk about the en bloc technique.
Thank you so much. It's my first time to Ann Arbor. It's outstanding. Thank you so much for the opportunity. It's also incredibly special to be here with Dr. Gilling. You know, one of the things I can say about you is that from the first time I met you, you've been so gracious for all of your accomplishments. You're so humble, and you know, I appreciate you've taught me many things. Been a mentor from afar. So we've been talking a lot about approaches, and I do think that the en bloc technique has gotten a lot of press, if you will, and I do think there's sort of different ways to do it, and I think we need to discuss the terminology a little bit. So I'm hoping to do that and also kind of show you a case of mine. So my only relevant disclosure is I am a consultant for Boston Scientific, and in this particular case, I was using the Moses holmium for the case. So really, when we say en bloc, really all we mean, because there's so many different things you can do at the apex, all you mean by en bloc is instead of 2 lobes or 3 lobes or 3 pieces, it's 1 piece. The entire transitional zone should be coming out as 1 piece. And that could be like 1 piece as a horseshoe, that could be 1 piece as a sphere, that could be, you name it. It's just 1 piece. Well, so here's the case I'm going to show you. 72-year-old guy, high-grade T1 bladder cancer, so getting lots of treatments. He's gotten BCG, he's gotten TURBT, he's getting surveillance, and he's actually gone into retention multiple times after these therapies. Has significant bother from AOA symptom scores on maximum medical therapy, has a 72 cc prostate, pretty thickened bladder wall, obstructed uroflow, and incomplete emptying, all the things that we would consider indications to do surgery. So what I'm going to show you here, let me start the video. Okay, so I'm going to show you here is a video of one of the ways that I do an en bloc technique. As I was saying before, I think I do every case differently now. I don't have one approach. I look at the prostate and figure out what it looks like at once, and that's what I do. That's where he had his resection. But I do like to identify the ureteral orifices if possible. And I like to start at the apex. So I do this so-called like an inverted U incision. Even if I were doing a 2-lobe or a 3-lobe, I still like to make this incision first. And I tell you why. It's like the capsule is beautiful back here. You can find it really nicely. And when you do that, if say you were going to make this into a different type of technique where you then go to the bladder neck like we've seen, if you've made this incision first, when you cut back towards the viewer, you just fall into it. And so you can like match up the planes. So now I'm going to show you, this is what I would call an early apical release. You're seeing the sphincter there. Okay, so you're asking about how we might be able to do an early apical release in an en bloc. This is one technique you could use. So in this case, I'm actually combining an anterior commissurotomy along with my apical release because it's a very short anterior commissure. And then I'm just going to make this circumferential incision in the mucosa. And much like what Joel was showing, this is not a really deep incision. And it doesn't really need to be at the beginning because I'm at least sparing the mucosa overlying the sphincter. I know I've done that because I've separated it. And yes, there'll be deeper attachments there, but I'll show you what I'll do with them a little bit later in the case. But what I love about this, particularly for the medium-sized prostates, if you will, is you can see so nicely right at the beginning of the case. The bigger prostates, sometimes there's bleeding back there and it's harder to know where to go. But I think in the smaller gland, for sure, it's really, really beautiful look at the actual anatomy. You can see the sphincter really well. You can see the mucosa really well. And then I do work, I think fairly classically from around this. Here I'm going around the left lateral lobe. I use probably a combination of both blunt and also, some laser, obviously. But I do think that we've gotten away all the videos you see online, they've sort of gotten away from using a lot of blunt dissection. And I think it's quite helpful, particularly when you're learning, to use a little bit of blunt dissection because it can help you find the correct plane. Here I'm just working over top. It's, much like I am using a Storrs resectoscope here, like Casey showed, same kind of setup. And I too move the fiber where I'm working. So if I'm working at 12, it's at 12. If I'm working at 6, it's 6. That can take a little bit of, that can be a little bit of challenge when you're learning, I think, because you're sometimes wanting to move both hands together because that's what you're used to doing if you were to do a TUR. But here you're whichever hand is doing the turning on the scope, for me, that's my right hand, really has to be independent of what my camera holding is doing. And so that's a lot of when I'm training residents, and we can talk about that, residents and fellows, I like get them to learn how to move the scope first. And there's different parts of the operation that I think lend itself to that. So now in an en bloc, okay, so I've done nothing else, worked around the left side and I've worked around the right side. And I was saying to you, if I have left any mucosal strip or I have left any anterior tissue, I can now cut it. I can see it beautifully. It's like a veil. And I'll just come right across. And I think here, it's so easy to see the crucial landmarks. We're talking about how to avoid the sphincter. And in some cases, as I said before, actually, in these old, frail, catheter-dependent patients, I'll leave some tissue back here intentionally. And I can do that with this approach. And what I tell my residents and fellows is it's really easy to see what to cut here, right? The bladder neck and the capsule are all going to be circular, and everything I need to take out is vertical. So I just need to cut across it. And then as I work forward, we're ultimately going to be working towards the bladder neck. You'll see here in just a couple of moments, the bladder neck fibers, you can tell where they are because they too will turn vertical. So you were circular, and then all of a sudden, as you're about to pop into the bladder, you'll see it's going to get thinner, and you're going to have vertical fibers. Hopefully you can see that there. I'm about to pop through here into the bladder. See how they now are vertical? That's how I know. I would say that I'm showing this, all the videos we show are so pretty, right? Like this isn't always so beautiful, just like this. So what I do to help when I make that anterior commissure, dissect out the bladder neck so that when I come around or I come from the distal to the proximal, I actually fall right into that space. And then I'm just going to take down the lateral attachments, which we've seen in so many of these beautiful videos. With the en-bloc technique, and I would say Wilson was one of our residents who did a fellowship out at UCSF, and I didn't do this technique at all when he was with us. I was like kind of classic two-lobe technique. So I think you should try all of them and then adapt to the prostate what works best. I really think that should be the goal when we're thinking about technique. I don't think one is better than another, but I am going to show you after this video some of the data surrounding the studies that have looked at en bloc. So again, just kind of I tend to be pretty I don't know, I like to have the counter traction perfect, and I like to be sort of maybe a little bit more slow and meticulous. That's my particularly in these cases where there's maybe a lot of vessels, or there might be here I'm showing you some multinodular BPH where you have these nodules. I think if I take the time and I just fire the laser in the correct direction, I'm going to actually get it to enucleate very accurately, very reliably, and that way I know I'm down on capsule. We'll just keep kind of moving slowly along here. And I think what makes the en bloc maybe a little bit more challenging when you are first trying to learn it compared to, say, a two-lobe technique. When you do a two-lobe technique and you get one lobe completely out of the way, you have lots of space in the fossa, which means you can then move the other lobe over. The counter traction is a little bit easier. You have some space. In an en-bloc technique, and this is the part where I'll show it to you, think about it like you're now anchored down in two corners, like sort of at 4 o'clock and 8 o'clock. So being able to get enough of that freed up so that you can take the entire transitional zone and roll it up the bladder neck, I think that's the challenge, because you really don't have a lot of space to do that. And when I find that I can often convert, like I'll start everything as an en-bloc, sometimes I'll convert it to a two-lobe at the end of the case, it's because I'm having trouble rolling it up the bladder neck, so then I'll just separate the left and the right side from one another. And then that's really helpful. But I would say if anyone was saying what cases the en-bloc harder for, it's the ones where we showed those MRIs where the bladder neck is so high because the gland is so large, it's really changing the angle of the bladder neck. So just, finish rolling this up, good counter traction, just push it up into the bladder. I think in the en-bloc here too, the sooner you get those corners freed and you can roll it up, the happier you're gonna be, because then it's just gonna show itself really nicely. You have to, when you're working up any type of bladder neck, you have to sort of anticipate the slope of the bladder neck, because otherwise you'll end up where you don't want to be, which is behind the bladder. Behind the bladder neck is a terrible spot to be in, and you will know it because you will see fat there. There's also, you have to be thoughtful in the bigger glands here. You really have to be thoughtful about can be an immense amount of vascularity along the bladder neck, and some really big vessels. And then we just come up and we're going to separate it at the neck of the bladder. So now it's all one piece. I would also say it's kind of nice when it's one piece to morcellate, because it doesn't go anywhere. It works really pretty well. Okay, so let's look at some. I'm just going to play this video here while I'm talking. So, I want to make sure that it's clear that early apical release is not synonymous with an en-bloc technique. So you can do an early apical release and do a two-lobe, a three-lobe. You can combine this with anything. But the intent or the purpose behind releasing the apex early, as I think we've said earlier, is really to try to spare the sphincteric mucosal ring, and particularly freeing it before you do that upward apical dissection, so that you're really not pulling, torquing, tearing any of that mucosa off of the sphincter. There are many different ways that have been published to do early apical release. You were asking this before. This is a V incision. I think that, I do not quite, I just sort of what I think is a circular incision. This is more like a V-type incision that spares the mucosal ring. A couple people have referred to the omega sign. And this was a study that actually looked at doing this omega sign, this omega technique of early apical release versus doing a Gilling technique, and looked at then stress urinary incontinence post-operatively, and felt that it was lower in the omega group at the day of catheter removal and at the first month. I would say when you really look deeply at these studies that look at continence, almost everyone's the same by 3 months. It's really this first month period of time that we're talking about. And here's another study that was prospectively looking at patients who were en-bloc with early apical release versus three-lobe. And this is 168 patients, and the operative time and the enucleation time were all less in the en-bloc technique. And when they looked at stress urinary incontinence specifically, at 1 month it was less in the en-bloc with early apical release than it was in the three-lobe, but again, no difference at 3 months. So it's just a study showing what I was indicating. I thought this was a nice study. Lots of patients, 600, randomized to en-bloc, two-lobe, or three-lobe. And perhaps echoing the sentiment of maybe It isn't so much which technique you choose, but particularly one that fits the prostate best. The en bloc and the 2-lobe, really, there was very little difference between them. I think they're only faster than the 3-lobe because you're not having to make the 5 and 7 o'clock incision. So they had shorter laser time, enucleation, and operative time. But in this study, in contrast to the one that I just showed you, there was really no difference in predicting stress urinary incontinence or urge urinary incontinence when you use the en bloc technique. And again, I think that's because you're looking at the 3-month time period. Again, this was more contemporary, looking at holmium versus thulium fiber laser, an en bloc and 2-lobe technique. Over 1,000 patients, more in the 2-lobe, 709 patients versus 406. Medium-sized prostates, 87 cc's, really no difference in surgery time or enucleation time, no difference in functional outcomes. And what was peculiar in this study was that the morcellation times were different. So if you had a bigger gland, your morcellation efficiency, was greater when you had the en bloc. Maybe that says something about, it being one piece versus multiple pieces, but I've not seen this data as far as changes in morcellation rate duplicated in any other studies. I'm going to skip that for the sake of time. And then just sort of showing you that have been multiple studies that looked at the different techniques. So this is systematic review and meta-analysis. And the take-home point is that I think 2-lobe and en bloc are very similar. I think 3-lobe takes a little bit longer time, so it's not as efficient. This was just a study that was looking at different en bloc techniques to reduce transient urinary incontinence. The original en bloc, an en bloc with a strip, mucosal strip detachment, which I showed you, or a 3 horseshoe-shaped incision, which I'm showing in the diagram here. Of course, these are authors that promote the 3 horseshoe-shaped incision and suggested that caused the lowest rate of transient urinary incontinence at 3.5% versus 14% in an original en bloc. And this is really coming to the end of my talk, but Joel will probably talk about this a little bit more in learning curve, but I have asked myself this question multiple times. Do I think the en bloc is easier to learn? This study suggested it was, that decreased operative time, better operative efficiency. If it is, I think it is easier to learn for a smaller prostate. And I think it is because it's very intuitive. You are not matching up planes. You're always in one plane. And in that way, I think when I have tried to then go from using a 2-lobe to an en bloc with our trainees, I do find that they have an easier time staying in the plane. It's just that when you start to get bigger and bigger prostates, I think being able to give yourself countertraction, having enough room to continue on an en bloc makes it a little bit more challenging. So it may be something in the middle. It may have to do with prostate size. So I'm going to stop there because most of these things I have already said, and I'm happy to take any questions from the audience.
So do you have any size limitations or anatomy limitations for deciding whether or not to start with en bloc? Sounds like you do it on everybody.
Yeah, so I start every case at the apex. Well, every case. I start at the apex with every case with what I think is going to be an en bloc technique. So I really try to free up the mucosa first. The only situations where the reason I was hesitating is you will find sometimes, these really big glands in the catheter-dependent patients have literally, they look like blood vessels the size of your pinky finger on the urethral mucosa. And so as you start to cut, and you're trying to, I showed you a beautiful example of like cutting that mucosa. If it's bleeding and you can't see and, that absolutely does happen. But I would say as far as the inverted U incision and starting up laterally, like I would for an en bloc, I do that for every case. Why do I do that for every case? Because When I used to do 2-lobe and I took out one side, maybe say take the median lobe with the left lateral lobe, the whole time I'm working on the right lateral lobe, that whole fossa and surface area and all of those vessels, which I tried to stop, are exposed, and I'm irrigating that space. So I usually wait, even if I'm going to turn it into a 2-lobe at the end, I'll wait to cut it till the end, because that way the prostate lobes are sitting on top of that surface area, and I am working in a really small space. So I think the chance of having blood loss or anything else is really decreased in that scenario.
Yeah, great, thanks, Nicole. I'm always interested in the honesty of people who write these papers and whether or not they own up to getting lost while doing the procedures. I mean, if you've got prostates over 200 grams, there'll be times during the case where you're not quite certain where the top incision is in relation to your bottom incision and so forth. I'd like to see a column in every paper. Did you get lost during this? And then if so, how many times?
Yeah, sure. Yeah.
Yeah, that's right.
Yeah.
And then you could sort of probably start to, because if you never get lost at any stage in a given case, I think there's a lot less between them in terms of operative time than if you're doing procedures that, where you find all of a sudden that you're not quite sure where you are and you're having difficulties and you're starting to yell at the nurses. But we never sort of measure that. I'm looking for more metrics.
Yeah, and I would say that exactly what you're saying about, one of the reasons why I often cut the anterior commissure, I was telling Wilson this, I often cut the anterior commissure and develop out the bladder neck, is so that when I'm coming around, I literally just fall into that space, so that I'm not trying to guess, well, where are those, like I showed you, where are those bladder neck fibers? Because in the big glands, you can be quite a distance when you come around from posterior to anterior. You're like in the mid prostate. You have a long way to go sometimes to get into the bladder, and it can be confusing. It can be scary, and I've guessed wrong a couple times, and all of a sudden I'm looking in the fat above. I've guessed wrong. Yeah. Okay. Thank you so much.
All right. Our last talk for the morning is about learning, and one of the things that we all touched on and think about is the steep learning curve. I like to tell folks actually the HoLEP learning curve is not different than all the other surgeries that we do. I mean, you have complicated surgeries, robotic surgeries, you have a lot of equipment, you have open cystectomies, where you need exposure, you have TURP, right? And people go, well, TURP is easy to learn. I go, TURP is easier to learn if you don't do a good TURP, right? Or green light's easy to learn if you don't do a good TURP with a green light. But to do it well actually is hard because you have to understand anatomy. One of the things that you learn doing HoLEP is you really learn the anatomy of the prostate. So now I'm going to invite Joel to come back up and talk about learning curve and how we can maybe do things better.
Thanks, John. So this is my favorite thing, and I get asked that question a lot, as I'm sure John does as well, as like, well, how did you learn? And I'm going to primarily focus on the slides, primarily focus on subdividing or compartmentalizing the operation, primarily for residents. But I definitely want to lean on one of my former residents in the room, Dr. Fung, who's going to be speaking later today. Provide some editorial if you want. Feel free to speak up. Because he was a victim of my teaching, and somehow he survived. But that's the thing, right? Is like if it was easy to learn, everybody would do it, right? If it's something that you could learn in 10 cases, and I think that's part of the misconception that John touches on, which is, oh, it's so hard. Well, I have a different talk where I touch on this. There's data that ultrasound-guided PCNL takes 40 to 50 cases to really become proficient at it. Why is that not a hurdle to how we are enamored with ultrasound-guided PCNL, and everybody wants to learn it? Yet 40 or 50 cases for HoLEP, oh, that's too much. That's a huge learning curve. It's how we perceive it, right? Again, I'm a proctor and preceptor, and my other editorial comment here is this is my why. We all find, like, we've all got families, we love our families, but my professional why is my residents and teaching, particularly how to do this operation. It is perceived as challenging to learn and challenging to teach. One of my former residents is at Ochsner in New Orleans. He did 100 HoLEPs in his first year in practice, and then they started sending the residents to him. And like after the first week, I get a desperate phone call of like, it's way harder to teach this than it was to learn it. So there's both aspects to this. Here in the United States, access during residency has been relatively limited. I mean, there are still programs in this country, I'm not naming names, who the residents are told clearly, do you want to learn this? You're going to need to do a fellowship. I'm not going to teach you as a resident. I was forced. I don't have a fellow. So if I want to teach anybody, I'm teaching my residents. And they all start as interns. I've got an intern on my service right now, and we're going to go through what he's focusing on as compared to my fourth year and what she's focusing on. But traditionally, it's been limited because, like, was mentioned earlier, 10 years ago, we all knew each other by name of who was really doing enucleation in the United States. But I think that tide is changing. Events like this help change that tide. But there's barriers that exist to adoption even after we finish training. And, as with any complex patients or any complex surgery, like I've got a third year who comes out of a room in clinic and is like, oh, she's got recurrent UTIs and she's got urge incontinence and stress incontinence, and maybe she's got prolapse, and oh, by the way, she's got a renal mass, and like, where do you even start? Like anything, compartmentalize. Develop your diagnosis and then deal with each one systematically. And when we talk about HoLEP, compartmentalize the steps in the operation and work through learning each of those things systematically. And it just is overwhelming until we do that. But when we break it down and are able to focus on developing proficiency in each of these areas, then we can, grow from there. When I was a resident, like I said, I remember reading that article in 2005 in Journal Club and being like, this is crazy. They take out 600 cc's or 600 grams through the urethra? Impossible. There were very few programs. There were very few masters, and really relied on fellowship training for people to learn how to do enucleation. And, there has been broadening of programs. There are more and more places where people are receiving training as residents. And I think that the training and approach surgically for residents versus an attending is different. And I will touch on that about what I recommend for techniques for people who are trying to learn on their own. Certainly our simulators have gotten better. Dr. Lerner knows my feet don't get wet with that weird tabletop suction cup model anymore that we had 10 years ago at the AUA. There are more hands-on courses. There's more people who are willing and able to provide, at the elbow support for your first cases or for your cases when you start to take on more complex anatomy. And I think that that's just going to continue to grow. I mean, in the there are a couple things that I think are standouts that I will mention. The course that Akil Das does at UC Irvine every year is incredible. It is a commitment on the part of the learner. It's not an afternoon. It's not 2 hours in a trailer at the AUA where you're speed dating, trying to learn how to do enucleation and teach enucleation. It really is a commitment. And we'll come back and touch on that. But to answer John's question from earlier, why did I want to learn how to do this? Maybe I like, doing things that seem like they're really hard. I tend to be a little bit of a curmudgeon about stuff and dog-headed and stubborn. I came back from attending a course that Tev Aho did at Cambridge. I had 3 green lights on the schedule the next week. We had the equipment. I said, we aren't a green light place anymore. We're doing enucleation now. And it was a struggle. But I I think that you have to decide philosophically, am I an enucleator or am I not? You know, we have to be able to walk before we can run. And it really needs to be your approach for every gland. It's not a tool that you're ever going to get over the learning curve if it's only the patients you find and your partners are referring to you that are 150 cc's. You are setting yourself up for frustration. So when we talk about, you know, segmentalizing the surgery, this is my approach with the residents. Laser fundamentals, scope mechanics, which we've touched on a little bit and we'll circle back to, morcellator use, hemostasis, lateral lobe dissection, bladder re-entry anteriorly, and then that anterior apical mucosa. And this is in the list of how I teach it. This is in my opinion, the level of difficulty of learning each of these kind of steps in the operation. So when we talk about laser fundamentals, like we've touched on earlier, working distance and fiber manipulation and understanding how the laser affects tissue. Trying to take a 3D model in your head from a two-dimensional image is challenging. And one of the things I say is that you want to work close. You know, even our eyesight, if we are in the three-dimensional world, is limited by distance. You know, you put two people at the opposite end of a football field, whether that's a pitch or American football, and ask somebody, who's closer to you? And they're 3 feet in front of each other and you're looking 100 yards away. It's a little bit hard to tell. To have those people stand 5 feet from you, it's obvious, right? So, you know, our three-dimensional perception collapses into 2 dimensions with increasing distance. And so we want to understand that we need to work close with the laser. We need to understand how the laser interacts with the tissue, and understand how we manipulate the laser so that we can be efficient with its use. Scope mechanics, as we've touched on and as other people have mentioned, my orientation, this video here, we're working at 1 o'clock, laser fibers at 1 o'clock. And this is particularly important, I think, that when you are early in your enucleation, you know, once you get most of the gland liberated, I feel like you can get a little bit lazy with that. It isn't as critical, but that passive retraction that your scope provides to expose that junction between capsule adenoma and those fibers that connect the two is really important. And, you know, there are people who do the exact opposite. You know, Fernando Gomez Sancha, he's the exact opposite and it works for him. And he is a master at this operation. So please take my opinions with a grain of salt. The beauty of this talk is I get to give my opinions. That orientation and working on that 3D concept in our heads of where we are in the gland. And this is, you know, if I'm got the 4th years on vacation and my intern's there, you know, I'm asking multiple times, where do you think we are in the gland right now? Are we proximal or distal? Are we at 2 o'clock? Or are we at 4 o'clock? And trying to get learners, resident learners, to focus on where am I in the prostate? Because you need to know where you are to know what you're trying to accomplish. And, you know, tension and haptics are really important. You know, here we're working anteriorly. We're bringing that dissection up over behind the left lateral lobe. You know, we're working close like we've talked about. And that high peak energy kind of gives us a roadmap. So, you know, I'm working right here, but I'm watching where that plane is moving laterally over to the left over the top of the gland. And again, these are real-time videos. Haptics. I am triggered, and Dr. Fung will support this. I'm triggered by how people set up everything for their scope. You know, it's the same way every time. My goal is to minimize the tugging and pulling on my scope other than that which the adenoma is providing. And so it's always light cord comes over the belly and then down to the scope. The camera cord comes over the leg. Don't flip-flop the two. And you've got to have your irrigation up on the belly so that your irrigation tubing isn't pulling your scope and you're feeling that resistance from your equipment. So teaching all that stuff, it's an early, easy step to get people started on this learning curve. Morcellator use, the most dangerous thing we use. Like my interns run it because if you have the right visualization, and I'm like Casey, I probably spend more time on hemostasis than most people because when you're on a rod lens, you've got the best visualization you're going to have. When you go to that nephroscope that's got mirrors in it, your light transmission goes down and your optics decreases. And so if you are finished with your enucleation and you're like, I think I can morcellate, you're not ready to morcellate. You want to be overly sure that you can see well enough, because you will never see as well through the nephroscope as you do through your 30-degree rod lens. Blade orientation and distance. My general rule is you can see the wolf, but you don't want to see a lot of bare shaft below it because then you're reaching out too far. This tends to be like a PGY3 technique of they can see the adenoma and they reach out with the morcellator and they don't move their scope, and then they grab the posterior wall of the bladder. So you can see the wolf, not bare shaft, and you want to see that full ellipse in your outer blade. That's kind of your minimum distance with the morcellator. I do both, what I call bottom up, and I do top down morcellation depending on how the adenoma is responding. So traditionally, this is the orientation that people are taught, is put the morcellator at 6 o'clock, suction, get under the adenoma, move it to the middle of the bladder, safe to step on the pedal. And you can see you've got kind of what we call the angles of safety. On either side of the blade, you can see that open space. You're not up against the wall of the bladder. I will say that, the idea of this is that you are moving to the middle of the bladder. The top down, where we're completely inverted, the blade's on the top. The idea there is you can't suck the trigone up into the morcellator, but you can definitely suck the dome of the bladder down into the morcellator. So we're a little bit organic with how we do that. I do think that having gravity kind of holding the lobe under you as opposed to trying to get it to sit on the top of the shaft, the top-down morcellation has some potential advantages. More to come on that, but at least our initial data is at least in experienced hands, it probably doesn't make much of a difference in regards to your morcellation time. Hemostasis is the next thing that we teach. And this is really the first point where the residents are getting sitting down, running the scope. All the enucleation is done. And again, just like we're compartmentalizing the surgery, we want to be systematic. Sometimes you'll get done enucleating and whether it's a big gland or a small gland, but typically it's the guy who's catheter dependent. It just looks like a red maelstrom initially in there. It can. And it's like, where do I even start? Be systematic. I start at the bladder neck, and I work circumferentially around that, but I also don't get stuck there. We'll do a couple passes and then we'll move into the fossa. We'll do lateral lobes and anterior capsule first, then we'll move down to the floor because there's always these little bleeders along the viru that you can coagulate 375 times and they always still want to bleed. It's kind of the last place we look. But again, getting that trainee to be comfortable with how far away do I need to be? How do I orient things? If there's like a little tucked bleeder in behind a little tissue, reaching out with the laser fiber. So you're just pushing that shaft of the working element into the capsule as opposed to trying to get this big thick scope in there to compress the more distal tissue. Then they work on hemostasis. Then we really get to like what everybody wants to do, right? The lateral lobe dissection. Oop, my bad. Come on. Told you I'd screw it up. One more. Got it. As I mentioned before, as a general principle, I try to teach work distal to proximal because you can see what you're working on. You're not trying to guess, how do I pull my scope back? How do I move my scope? How do I rotate my scope and not apply undue tension on it? And so we can work kind of gracefully around the lobe. When you're working proximal, you can see it. And the other message that I like, my mantra is about this is that if you're unsure, pull back and look. So distal to proximal, pull back and look, because you'll get one of these multinodular glands where you take your posterior dissection up, and like, okay, well, I'm going to do a 2-lobe, so you do your anterior commissure and you take that laterally and it looks beautiful. And like, why doesn't it connect? Well, you've got this huge onion peel that you've raised. It all looks like smooth tissue. And like Peter said, you get stuck. And you've got to be able to identify that and treat it. And you've got to pull back and rotate and really look and see, where does this onion peel originate, and then correct it as you move towards the bladder. Bladder reentry is kind of the next step. So this is kind of a mid-year resident thing too, mid-level resident thing, where I've finished the apex, and I do re-enter the bladder over the top pretty routinely on block. And it's kind of that relatively safe zone between 10 and 2. I usually turn that over when we've reached, what Chandler Dora calls is kind of the fulcrum of the adenoma. Because if you've got a lot of anterior adenoma, when you're really distal, your hands are low, your scope's aimed up, you're trying to get on the capsule, but you reach this point where you can actually rotate level with the patient, and you've got more of a straight shot into the bladder. And, again, getting that straight shot, identifying those bladder neck fibers, and re-entering the bladder. Relatively safe space. I spend more time watching their hands than I do watching the screen, because I want to see them get level and not go too far. Everybody's afraid to go, in front of the bladder. Everybody's afraid to punch a hole in the capsule. But in a really mature capsule, you can start to dive down, and you're not on the true bladder neck. You're popping out in the proximal prostatic urethra and leaving some anterior tissue. And so I call it surfing. I want you to apply, passive pressure on the adenoma, but I also want you to be moving your hands up and around, kind of in a semicircular pattern, and surfing across the gland instead of applying undue pressure on it. Because when you apply that undue pressure, really good example from this week. My 4th year was at this location, and we were just not getting back into the bladder. That's the point where I do, as Dr. Miller mentioned, I'll go make the anterior commissurotomy. I'm like, we're just not getting in the bladder. So go make the 12 o'clock incision. Connect to this plane you've developed. It's going to show you where the bladder neck is. She was at like 9 o'clock. She had kind of like slipped off the whole side, and what we were going, if we had entered there, we would have been at like 9 o'clock on the bladder neck, not up at 12 o'clock. And as I mentioned in the other talk, that widening of the bladder neck, the bladder neck fiber recognition, you can start to see we're getting some vertical fibers there. And when we go to widen the bladder neck, I work from fossa back into the bladder neck, not just trying to take the bladder neck laterally right up below it. And then that advancing mucosal curtain, anterior apical mucosa, is really kind of the last step in technical difficulty. And, I think that part of the hard part of teaching this is that with how we do this now, this is like the first part of the operation. Everybody can kind of get onto the capsule posteriorly, but that anterior urethra can be challenging. You're trying to connect these two planes under direct vision. Your scope's kind of floating in the membranous urethra, looking into the prostate, and just what I call it, translating your scope, moving your scope so that you can take that down under direct vision. Technically it's the most difficult thing, and it's the first thing you got to do. So it's actually one of the last things that I teach them, is to do this. It's about following that contour. I will do sometimes an anterior mark. So you can see the mucosa is hanging down here. You can see a view of the other side coming up. And it's really obvious here, right? Again, videos at this stuff, everybody's highlight reels, not their behind the scenes. but we can see what's left of the anterior urethra here relatively easily. And you know, I'll do a 12 o'clock mark sometimes if I want to, if I'm trying it and it's challenging, simply because it segmentalizes, like we're talking about the whole operation, the distance I have to translate my scope in the correct orientation. So it's like, just get us from 10 to noon, and then we'll come over and work from 2 back to noon and get it connected. I do think that it's a stepwise progression of skills for residents, and I think that resident training advice is different than I give to people who are learning this in their practice. And it's kind of, I've kind of evolved. You know, when I started doing on block, I do think conceptually it's easier. I do think that it is faster. But you're kind of, what I like, anybody else play poker, you're kind of pot committed, right? Like you're getting this whole plane early, which is nice, but you don't have any mileposts along your enucleation to assess your progress. And it's tougher, I think, to have a bailout. So I tell people in their practice, I actually am inclined to say, learn a 2-lobe technique, or if you've got a big median lobe, do 3 incisions for those particular reasons. Number one, you know, anesthesia, time, OR, schedule, life, like plan on, you're going to do your first few cases. And I tell people, I don't care if it's 65 cc's, plan on being there 2 to 3 hours. But also have some check marks, some mileposts, like, okay, I'm going to do the median lobe. I've got to get the median lobe enucleated in 15 minutes. Circulator, John, Dick, or Harry, tell me when 15 minutes goes by. Like, okay, I got it out. All right, now I'm going to go to a lateral lobe. I want to get this lateral lobe around at 12 o'clock and get my anterior commissure done in 30 minutes. And let's say it took you an hour because you got a big onion peel. We all get them. I still get them. It took an hour and 10 minutes. Okay, well, maybe that's a case where we're gonna, you know, get out of Dodge. We've got the median lobe out, we can get the left lobe out and leave the right lobe and stage it. You know, Peter knows Andy Southwick. Andy Southwick used to be at University of Utah at the VA. I taught Andy. After 6 months, he's like, I don't see any prostates under 120 grams. It's like, I stage you know, in his first like 50. There's no harm in that. And there's also no harm in saying, well, I got the median lobe out, I got the left lobe out, the right lobe I don't really want to leave behind. Get your bipolar out and loop it. You know, those aren't failures. You know, I think that we are philosophically taught, like, we've got to be superstars, and it's very hard to be learners again as attendings. You know, my first HoLEP I ever did, I left the right lobe because we hit like 3.5 hours and I was ready to cry and anesthesia was ready to kill me. And about 4 years later, that guy came back with hematuria and had a bladder tumor. And to this day, I get to scope him once a year and look at his right lateral lobe that he will not let me take out. And the first time I scoped him, I looked through his membranous urethra and sphincter, and I was like, oh God, he's scarred off his whole fossa. Well, you had to make a turn to get around the right adenoma that was filling the guy's fossa, but his peak flow is 16. You know, and you retroflex and you look at this thing, and I'm like, I really should take that out. No, I'm great. And he is. So, like, staging, changing your modalities, particularly in your first 20 or 25 cases, if you're learning this on your own, is not a failure. You know, I think that we're failing our patients if we're compromising doing what we know has the greatest durability in treating outlet obstruction. And, you know, we work from simpler moves to more complex moves. When you're a resident, you move from simpler cases to more complex cases when you're learning as an attending. My advice, 75 cc's plus or minus 15. No redos, no 4 KTPs, 3 prior terps. Like, virgin cases, 75 cc's plus or minus 15. You're going to have a consistent mature capsule, but you aren't going to have so much real estate over which you have to work that it's just, you get lost. Work distal to proximal, pull back and look. particularly for those people in academic programs, structure rotation for repeated experience. You know, when I started teaching residents, they didn't get to spend any time with me as chiefs. It was all a 3 and 4. And so like one of our guys like finished his 4th year rotation with me. He did 182 cc prostate in 65 minutes. I remember it to this day. He doesn't do them in practice because he went a whole year without doing a HoLEP, started his practice, didn't have partners who shuttled him cases, and he didn't feel confident anymore. So we restructured our residency. And when we did so, the chief residents spend 2 months with me doing HoLEP and with my partner doing ultrasound guided PCNL. So each chief gets 2 months. So that's within the last 6 months of graduating. And since we did that, every single resident is doing HoLEP in their practice, except for the guy who decided to do pediatrics. Probably a good thing. But you've got to set up your system to make sure that people who are, you know, people are set up for success. It is the technically most difficult thing I've ever learned. And so like having it fresh in your mind is important. There's a role for junior residents, there's a senior resident role, and then that chief dissertation, in my opinion, is been key to our success. And of course, I saw the paper 2 days after I turned in these slides, but Jim and Mars just published on this at like the beginning of the month. They looked back at all of their resident graduates at Indiana for the last 5 years. 100% are doing enucleation, and 90% felt confident when they finished residency. So it is definitely teachable in residency. It's definitely something that you can learn once you're done. You know, John's an example. I'm an example. We've got multiple examples in the room of people who've successfully done that. But you've got to kind of commit. Lola. Thank you.
Great talk, Joel. So I'm curious, the way that you teach residents, how many cases would you take them through before you say, yeah, I think they got it, like they can do it?
I think like anything, you know, there's a spectrum, right? Like, you know, like Mike did probably 20 cases with me and was at the place where I'm like, I need to be here, but I probably don't need to be here. You know, there's those residents like that, like those are the joys, right? Like who have technical ability out of the gate for whatever reason, have a great sense of 3-dimensionality in their head. So, you know, on the other end of the spectrum, I've got a former resident who we taught who, you know, had Guillain-Barré, you know, he's got a movement disorder, you know, extended his residency by 6 months and does them in practice. So I think technical ability is going to be a big effect on how many cases, but if you had to pin me down, I think it probably takes 20 to 35 before I really feel like they've got everything other than the apex. The apex is going to be, there's high amplitude. You know, one case, they're a superstar, and the next case, I got to put my hands on the scope. You know, Amy describes it as, I want them to move from me being a teapot where she's reaching over and helping them run the scope, to a sugar bowl where she just gets to stand there like that. But somewhere around 30. You know, I asked my 4th year earlier this week, knowing I would probably get that question. You know, on Monday we did 4 cases. She did. I touched the scope once on the 200-gram prostate at the apex. She did everything else with minimal direction. She's done about 70, and she's got another 1.5 years with us. So, but I think it's early exposure and it's just repetitions, people. It's not magical skills.
I just want to say thank you, Joel. I obviously would not be sitting here without you. You know, 5 years with you as a resident. So thank you for all your mentorship and your friendship. You know, over the last decade I've known you now, you've always been there for me, and so thank you. I would also say, like, during the cases, you know, it doesn't always go swimmingly, obviously. There's always times when especially when I was learning. I remember I'd leave the room and I felt like 6 hours went by. I was like, oh, it's only 2, but I had the worst migraine ever. It's just a different way of thinking. But even now, still, there's some times when the gland is super sticky. You feel like going up a cliff. And in those cases, I find that I channel your inner voice. I hear you yelling at me.
I don't yell. I do not yell. He's also on record as saying, I've never heard you yell at somebody in 5 years. So maybe I get, curt.
Yeah. But I would say, like, during the case, some things that help me when I get frustrated is to go to another part of the prostate.
Right.
When you're really
Great point.
stuck there, it goes from 3D to 2D very quickly when you're just sitting in one place. And that makes the case so much more difficult. And so I find helpful for me is I go to another place. And something about moving from side to side, seeing the gland move, it helps with my 3D intelligence. It helps me know where to go next. And when you start nucleating another portion of the segment of the prostate, going back to that stuck area isn't as bad. For some reason, it's just more mobile.
Right. Great point that I missed in this, and it's not anything that I made up on my own. It was something somebody who taught me something very different than HoLEP, RPL&Ds. If it's hard right here, go to a different spot. And you're going to come back to that spot with a fresh set of eyes. Not only are you going to come back with fresh eyes, but because, in my opinion, because you've mobilized the gland elsewhere, perhaps the tensions are different when you come back there. The movement of the adenoma is different. And having that adenoma move and rotate around your scope as you're enucleating is critical, I think, to maintaining that 3D model and maintaining that plane of dissection. If it's just like a wall of tissue, like that's one of those places where I'll tell people, like, okay, you can see it rotating, you can see it separating up kind of the leading edge at the top of your view as you go past 3 o'clock. When it stops doing that and it just feels like you're cutting through tissue, pull back and look, see where that plane goes and continues. And a lot of times you'll see these fibers crossing from adenoma distally to capsule proximally. Oh, okay. I got to cut up through that, and then I can rotate past that point.
Yeah, great talk. And I just want to say also, I learned it in practice as well, just like you and John, and it is very hard. I want to also show appreciation for what you did for me, because I came out and visited you when I was first after the course that I took, and then you came out, proctored me on my first couple of cases. Which was great. You didn't have a license, but in California, but you came out anyway, which was really, really wonderful. And I don't know of anybody else who would do that, quite frankly. Mike is incredible, and when the way I heard about Mike was, okay, there was a guy who was doing morcellation for a lot of people in Southern California. He was running the machine, and he works with me, and he was like, you got to see this guy at UCLA doing his fellowship. He's actually teaching them how to do HoLEPs at that point. And so I thank you for Mike as well. Really what I wanted to say is that, I think we all know that there's people who can do HoLEPs. I think there are very few people who teach it well. And I think what you have is probably the right system of doing it. I appreciate your honesty too in kind of like saying that, people will put their best videos on there. It's like any DIY video on YouTube.
Right.
Nobody's going to show like the shelf falling off the wall and smashing you in the head.
Right.
On YouTube. That's not good, right?
I get about 275 takes a year to get one video for you guys.
But the other part of it too, I think is like there's a legend about this operation that John kind of got to, which is like very discouraging for a lot of people who might want to do it, is that, it's so hard to do. And to some extent that's true. But how do you kind of like, what do you tell people who want to learn to say that, it's doable, it's not easy, and try to give them like sort of a realistic picture of what they're getting themselves to, right? Because you can't learn this thing just watching YouTube. You're not going to learn it that way. You actually have to come and see people to do it.
Everybody makes it look easy.
Right? Yeah, exactly. But what do you tell people about the learning curve and in a way that kind of like encourages them to actually try it and adopt it?
So we touched on it a little bit. 70. I say your first dozen cases don't vary from the algorithm. 75 cc's plus or minus 15. Okay, 100 gram because the guy's in retention, but that's gonna, don't do that as your first case. Don't learn from my mistakes. That guy I didn't do the right lobe on was like 140 cc prostate. Not good patient selection. So rigorous about your patient selection. Don't do more than 2 in a day in your first 25 to 50 cases. Schedule them for 3 hours. You've got to be consistent about your repetitions. You can't do 275 gram prostates and then have it be a month until you do another case. The people I see who have the most success, who are learning after residency, they come to me with like, hey, I've got an Excel spreadsheet of 16 patients who need a HoLEP. And like, I've got to learn. Like, and the follow-up to that is, and my partners want me to learn. It truly takes a village, and if what they kill, it's going to be really challenging unless you already have a BPH predominant practice. Look at your numbers. If you're not doing, 60 or 100 somethings right now for BPH, you've got to figure out how can I get the volume to be doing that number of cases. You want to do 25 cases in your first 4 to 6 months because you just got to get the repetitions. 2 cases a day because you're going to be tired and you're going to be cognitively fatigued. And then it touches on the other point, and it's more of kind of like a systems building talk that I've got. But one of the points of it is you have to minimize your cognitive load when you're learning this. You can't, we all deal with it, right? Like you don't get the same circulator every day. You don't get the same scrub tech every day. For Dr. Dow to have a scrub tech who's never run the morcellator in his room at this point, not a big deal because he's mastered the operation. He has cognitive energy to help that person learn. But when you're trying to learn, you also cannot be on every case making sure that both of your fluids are running in full and making sure that your morcellator canister is getting changed when it's full and making sure that the adapter bridge is on your store's nephroscope. So my advice to that is it's worth the meeting with your perioperative team. And I'm learning. I can teach the team, but I can't have a new circulator every case or every time I come do these. Give me the same circulator for the first dozen cases. Have them learn, then they can teach other people because I can't concentrate on helping teach them how to run the morcellator and safely morcellating. Even at our institution still, it is verboten. New circulators are not allowed in the HoLEP room unless they have been proctored by a circulator who knows how to run the morcellator. Right? It's a setup for frustration because, the wolf thing, it's like, the thing that triggers me is like, okay, the canister's full, we need to change it. And it's like, what button do I push? And well, how do I just move the top over? You got it. They don't understand that the more time you're not running that blade or running the suction, your visualization goes down by the second. And so the circulator who can change it in 20 seconds, because then you're just waiting on the dang pump, right? Doing it lackadaisically, that's my message is you need to be intentional because time is bleeding and bleeding is visualization. So maybe more of an answer than you wanted.
So you mentioned staging, especially for complex cases when you leave the right loop. So how soon you bring the patient back to the OR, and what do? You do a second HoLEP or you do a TURP, and how you bill for that?
So I've never successfully gotten someone back to the operating room because they're all happy and they all empty and they all have great flows. So I don't know if you have to take out the other lobe. And Andy's experience was the same at the VA before he moved to New Zealand, which is that he had a bunch of patients that he had left lateral lobes in, and to his knowledge, nobody went back and had to do completion. But you just use, you can go back and code it with a 59 modifier if you want to be really honest. Or if you're following up with them and they still have any either subjective or objective parameters of obstruction, it's the same way I get paid to do a HoLEP after somebody's had 2 terps and 3 green lights and has a 212 cc prostate left. Medicare will still pay for it. As far as time frame, I think it's dictated by those factors, subjective and objective parameters of obstruction.
If you are taking him back, are you considering HoLEP or TURP, just like
HoLEP.
Second HoLEP?
Yeah, HoLEP the other lobe.
Yeah, this is not a question about the technique, but about a lot of those patients have overactive bladder, and Amy is doing some of them. She puts Botox on those patients. Have you had any experience from that?
Yeah. So I will offer patients who have baseline urge incontinence, I will offer Botox at the time of their HoLEP. Amy's got has published some data. I'm more comfortable doing that now that there's published data. I was much more hesitant until we knew that those patients wouldn't be at a higher rate of postoperative retention. So that's kind of my primary criteria, is the guy who's got baseline urge incontinence, and you ask them, like, what bothers you the most? And they're like, oh my God, I can't get to the bathroom in time. Those guys, I will offer them Botox at the same time.
Okay, one comment, one question. So the comment I would say about teaching, in every other, particularly oncologic operations, we tell, if anything that's done with the robot, you should go back and you should watch yourself operate, watch your videos. I don't think this is any different. You should, when you're doing your first case, you should video them and you should go back and you should watch them, because it's amazing when you have the time and the cognitive rest where you don't have the stress of the operating room. You're like, oh wait, yeah, I should have done that differently. I see it now when I didn't see it like in the moment. So I think that's my one comment, and could not agree more about changing your so that the exposure to HoLEP happens at different levels of training. For the first 10 years, I was the only one who did HoLEP, and I got a PGY3 resident for 3 months, and I never saw them again.
Right.
And they had no exposure anywhere else. There was no way they were going to be
Right.
able to do the case. My question to you is, this is going to be a harder one. Why should anyone learn how to do this operation? It's not reimbursed for the effort that's required. It's not reimbursed for the learning curve that is required. And if you were in practice, and perhaps these folks can answer, you're not incentivized to learn this operation. I do it because I see a lot of really large glands, and I don't think that they should need to have incisions in a big, expensive robotic case in order to get their BPH treated. And I also think I'm getting to heaven faster because these patients do so much, they do so well. I think that, it's in the outcome. So I feel like we've really been failed at the legislative level with this operation. If you get paid more to do a PCNL that's greater than 2 centimeters, why are we not getting paid more to do a prostate that's over 100 grams?
Right.
Comments?
Yeah, I think in some ways you've answered the question already for yourself, Nicole, in that, you do this. Nobody does this because of the financial compensation, right? Like I don't see people typically at meetings or courses that I teach who are like, oh yeah, I do 80 aquas, every 2 months, or I do 7 aquas in a day. Those people aren't interested in it. I think that it is a philosophical difference between those who want to learn how to do what we know from a data standpoint is the number one thing. It is the gold standard. I mean, that's Jim's editorial from like 10 years ago from Journal of Urology was, it is the most rigorously studied over the longest term data with the largest number of randomized controlled trials. And so, people are drawn to it because they want to do what is ethically right for their patients and their patients' long-term bladder health. So, you're not going to do it. You're going to do it for that, or you're going to do it because you're stubborn, or you're going to do it because you want the, a lot of us, like initially, it's like the technical challenge, right? It's like,
That's why we're at 7%, 10%. I mean, because it doesn't
right.
work in
And
a business model.
I mean, and you were involved in those emails. I know Lori was, 12 or 13 years ago when it was devalued, right? Um, and I kind of hope and don't tell Peter when the ruck happens next year for Aqua. I think that we're going to see a further shift, at least in this country. But yeah, so the way I get around that is that you can bill a 22 modifier. Any case that goes over 2 hours, we document all of our case times in our operative notes. Anything over 120 minutes, we attach a 22 modifier to. So you get a little bit more. But it's never going to make financial sense. But, we could, PCNL, right? Like, patient has 7 ESWLs for a 3-centimeter renal pelvis stone before they get referred to somebody for a PCNL that's going to take 3.5 hours, right? There is an ethical difference between those two groups of physicians.
I think that's why we see differences across the globe, right?
Right.
We were just in South Korea for the World Congress. 60% of the prostate procedures being done in South Korea are HoLEP.
Right. And I mean, I think even in other countries where you don't have a socialized, Japan's great too. I mean, Japan, everybody gets a HoLEP, you look at some, third world countries that are incredibly referral based, where there's like 3 urologists. So families travel and stay in town in India for a month and a half. They all get a HoLEP. Mexico, there are more people in Mexico. I would bet that percentage-wise, the number of urologists who are learning or have learned enucleation in Mexico is far higher than it is in this country. And there's all those factors. HUG is a great example. HUG makes it easy for the England, Scotland, and Ireland because it's a national license, and TEV can actually go and help somebody, and put hands on. So you're right. There have to be legislative solutions to some of the systems-based barriers to broader adoption here.
Yeah, I would just make one comment. I completely agree with you, Nicole. It would be great if there was a system like we use for TURBT, where we're compensated more
Based on size.
100% agree. I think there is kind of like a light at the end of the tunnel, though. Once you have gotten over your learning curve and you use the transition from Padawan to Master, probably even before then, a person like you, Joel, is seeing a practice enriched with 250-gram prostates, and that is going to limit the in and out of the room time, no matter how slick you are.
Right.
If you're in a situation where your partners are bought in and people are agreeing that TURP is maybe not the ideal surgery, it's not a bad surgery by any means, but not the ideal surgery for most glands, you can have a day where you do 6 HoLEPs and each one takes 1 hour.
Right.
Because you're doing, 80-gram glands. And so in that situation, and we've looked at this departmentally, the RVU density for a case like that, where you're getting 14.5 RVUs for an hour of work, is through the roof.
Right.
Really, probably only prosthetics and quick PCNLs are going to be the only other things that can compete with that.
And you come back to systems-based things too, right? Like I get asked, well, how many, you're over your learning curve. How many do you do in a day? My answer is, I got 1 morcellator. And in my system, I get 1 room. If you are in a system, or you can structure your system like Amy or Mitch has, where 2 rooms, a fellow, a mid-year resident, 2 morcellators, 3 lasers, even if you're doing 150-gram prostates, you can do 8 or 10 in a day and do 400 plus cases in a year. So a systems-based thing where you've got to have your hospital system buy into, it's worth investing the staff and the capital to position this urologist so that they can crank out the cases. And yeah, it's financially beneficial, but it's also patient-centric too, right? Because right now, if I see a guy, he's getting booked for mid-January. Like that's not very patient-centric. But if I had 2 rooms and the equipment to do twice as many cases in a day, well, your lead time automatically is cut in half. So, I mean, we can cut and slice this however, you guys read, my Twitter, I'm a HoLEP fanatic. Because it is, and it is the best from objective standpoint. It is learnable, it is teachable, and these are, again, those two hats that I wear. The only other patients in my practice who are as happy as HoLEP patients, female sling patients. They're the two happiest groups on the planet.
So we know HoLEP is gold standard, but the guidelines don't say it is yet. So what does it take to change that in guidelines? Do we have to pass that tipping point so that everyone can adopt this?
I think Dr. Lerner can speak to that.
Yeah, I'm just sitting here just listening to the chatter, but between the guidelines, well, yes, I did wear that hat, but to get to the funding point, so you guys, how many here have gotten a request to fill out one of the RUC surveys from the AUA? How many of you have actually done them? Okay, so reimbursement is a very tricky thing, and so when Jim and I went to get reimbursement for HoLEP to begin with, you have to go before CMS and you have to do a lot. Now here's the thing. It means that something else has to come down. And I don't think people understand that concept. They have a net neutral that they want. So if you're gonna fight to have your reimbursement go up for a procedure, then they're gonna reduce the RVU workload for another. So if you're looking at the number of TURPs that are done, and if you're thinking about the constituents of urologists, do we want to penalize what's being done more often than our small volume of HoLEP for the purposes of reimbursement for what it is that we personally do? So the reality is there's so much more that goes into these decisions. So we don't have the adoption that makes it make sense to increase that reimbursement so much. Now, one could say, well, if you increase the reimbursement, that it will propel people to doing more. I mean, that's just not how it goes, right? Like cataracts are a perfect example. Cataract reimbursement was super duper high initially because they were getting it out of the operating room and doing them some sort of in the office. And so they reimbursed people really well to do that. And then they realized we don't need to do that anymore. They cut it back. Now people aren't going to stop doing where it is that they do cataracts. But where will we get to that point? So I think it's a very complicated thing. And when those REC surveys come out, it's really important that people complete them, but you just have to realize that there is a back end cost that comes to that. The other thing, and Peter and I were talking about this earlier, is that insurance companies also determine what they do. And if any of you are involved in your hospital politics, you may say, hey, we do a lot of HoLEPs here. We want to see higher reimbursement than what the Medicare reimbursement is at our hospital. So Blue Cross could say, okay, that's fine. We're going to reimburse your HoLEPs higher. What do you want us to drop down? Right? So, at our hospitals, we felt that we were not getting enough reimbursement at BI for cardiac surgery. And the group that took the hit was urology. So the urologists were at the table saying, look, you're reducing our reimbursement because you've negotiated a deal with Blue Cross to have higher reimbursement for cardiac surgery. That's how it goes. So, you have to be at the table and say, who's going to take the hit for somebody else from a business structure? If we're not at the table, we're not going to be part of some of that decision making. But anyway, it's very complicated. And I think like everything, understanding these processes is super important. And so from a guidelines perspective, in the BPH guidelines, every decision we make has to be with what do we think ethically, but how do we not hurt urologists, right? And one of the biggest things that I would love to see, and Joel and I are exactly the same, and most of the people in this room, we want to know that you're checking a flow rate on everybody. We want to know that you're checking your own data, that that we're asking you to do that. But if we require that, then you might not get reimbursed for a visit if the patient voided the second they got out of their car because they couldn't hold it until they came to you. So we come around and around that the only objective parameter we could put on improvement for BPH was IPSS. We can't objectify BPH. We can objectify it in this room, but you can't objectify it in such a way that the guidelines, you actually hurt the people who are doing this because you can't get the patients to do what it is you want to do. So think about all of that. So it makes our guidelines super frustrating as opposed to cancer guidelines, which are very, they're very specific. They go through, this is what you're supposed to do. And so as a result, we spend 6 years on the guidelines for people to kind of not pay any attention to them whatsoever. And that's a hard, hard thing to swallow when for a long time that's what you did. But hey, I get it. So all of this comes into the picture of what we're trying to do. This does not exist to the same degree outside this country. So, we see patterns that are different for a lot of various different reasons. So that was a very long answer, and I'm sure everyone's ready to go to lunch, and I may not have even
I'm just
answered the
gonna
question to begin with,
Put
but
forward for lunch discussion. What should be reduced in reimbursement, and why is it mid-urethral sling?